Hello everyone. So we will be starting with chapter 11 of illustrated textbook of pediatrics, that is neonatal medicine. Features of neonatal medicines are hypoxic ischemic encephalopathy is a major cause of death and neurodevelopment disability worldwide. Premature infant, especially those born at very early gestation, 23 to 28 weeks, have many short and long-term problems. Jaundice is common in newborn infants. The aim of its management is to identify any underlying cause and prevent kernicterus. Newborn infants are particularly susceptible to group B streptococcal and other infections in the first 3 months of life. Although craniofacial and serious gastrointestinal abnormality are usually detected on antenatal ultrasound screening, they may present in neonatal period. The dramatic reduction in neonatal mortality throughout the developed world has resulted from advances in the management of newborn infants, together with improvement in maternal health and obstetric care. Neonatal intensive care became increasingly available in the UK from 1975, and since then, the mortality of very low birth weight infants has fallen. Most babies do not require any additional medical care after birth and are nursed alongside their mothers. This is the dramatic fall in neonatal mortality rate in England and Wales in the second half of the 20th century, according to birth weight. In very low birth weight infants, that is less than 1500 grams, the marked falls in the mortality occurred after the introduction of intensive care in the 1970s. Now, the well babies are given to the mothers in the maternity unit. Some babies require transition care where some additional monitoring or care is required. For example, a baby is born at 33 to 37 weeks gestation. This is usually provided with the baby nursed alongside his or her mother on the postnatal ward in the maternity unit. About 8 to 10% of babies born in the UK are admitted to a neonatal unit for special medical and nursing care, although whenever possible, babies should remain on the postnatal wards to avoid separating mothers from their babies. In the UK, neonatal units are organized as networks, with units providing either special care level 1, short-term intensive care level 2, local neonatal units, long-term intensive care level 3, neonatal intensive care, usually linked to specialists, fetal and obstetrics. To form a specialist tertiary perinatal center, about 1 to 3% of babies require intensive care. Modern technology allows even tiny preterm infants to benefit from the full range of intensive care and cesarean surgery if it is anticipated during pregnancy that the infant is likely to require long-term intensive care or surgery. It is preferable for the transfer to tertiary center to be made in utero. When a baby requires transfer postnatally, transport should be by an experienced team of doctors and nurses. This is often organized to serve a number of neonatal units in a regional network. Arrangements should also be made for parents to be close to their infants during this stressful time. Hypoxic ischemic encephalopathy. In perinatal asphyxia, gas exchange, either placental or pulmonary, is compromised or ceases altogether, resulting in cardiorespiratory depression. Hypoxia, hypercarbia, and metabolic acidosis follows. Compromised cardiac output diminishes tissue perfusion, causing hypoxic ischemic injury to the brain and other organs. The neonatal condition is called hypoxic ischemic encephalopathy, HIE. It remains an important cause of brain damage, resulting in disability or death, and its prevention is one of the key aims of modern obstetrics care. In high-income countries, approximately 0.1 to 1 per 1,000 live born term infants develop HIE, and 0.3 per 1,000 have significant neurological disability. The incidence is higher in low and middle income countries. Most cases of HIE follow a significant hypoxic event immediately before or during labor or delivery. These include failure of gas exchange across the placenta, excessive or prolonged uterine contractions, placental abruption, ruptured uterus, interruption of umbilical blood flow, cord compression, including shoulder dystocia, cord prolapse, inadequate maternal placental perfusion, maternal hypotension or hypertension, compromised fetus, intrauterine growth retardation, anemia, failure of cardiorespiratory adaptation at birth, failure to breathe. The clinical manifestation starts immediately or up to 48 hours after asphyxia and can be graded mild. The infant is irritable, responds excessively to stimulation, may have staring of the eyes, hyperventilation, hypotonia, and has impaired feeding. Moderate, infant shows marked abnormalities of movements, is hypertonic, cannot feed, and may have seizures. Severe, there are no normal spontaneous movements or response to pain, tone, and length may fluctuate between hypotonia and hypotonia. Seizures are prolonged and often refractory to treatments. Multi-organ failure is present. The neuronal damage may be immediate from primary neuronal death or may be delayed from reperfusion injury, causing secondary neuronal death from secondary energy failure. This delay offers opportunity for neuroprotection with mild therapeutic hypothermia. Recording of amplitude integrated electroencephalopathy, encephalogram, AEG, cerebral function monitor may be used to detect abnormal background brain activity to confirm early encephalopathy. It is also used to identify seizures. Management, resuscitation, stabilization will minimize neuronal damage. Infants with HIE may need respiratory support, treatment of clinical seizures with anticonvulsants, fluid restriction because of transient renal impairment, treatment of hypotension by volume and inotrope support, monitoring and treatment of hypoglycemia and electrolyte imbalance, especially hypocalcemia. Recent randomized clinical trials have shown the mild hypothermia cooling to rectal temperature 33 degrees 33 to 34 degrees for 72 hours by wrapping the infant in a cooling blanket. For infants 36 weeks gestation over with moderate or severe HIE reduces brain damage if started within 6 hours of birth. Analysis of these trials has demonstrated that for every 8 babies cooled, 1 extra baby survive without disability. While schooling has become the standard therapy in the UK and many high-income countries requires neonatal intensive care facilities not available in most low and middle-income countries. Figure presents outcomes of therapeutic hypothermia trials compared with standard care for the treatment of near-term babies with hypoxic ischemia and encephalopathy. Prognosis: when HIE is mild, complete recovery can be expected. Infants with moderate HIE who have recovered fully on clinical neurological examinations and are feeding normally by 2 weeks of age have a good long-term prognosis, but if clinical abnormalities persist beyond that time, full recovery is unlikely. Severe HIE has a mortality of 30 to 40%, and if survives without cooling, over 80% have neurodevelopmental disabilities, particularly cerebral palsy. Even with cooling, mortality and long-term neurodevelopmental disability rates are high. If magnetic resonance imaging MRI of the brain at 5 to 14 days in term infant shows significant abnormalities, there is a high risk for later cerebral palsy. Hypoxic ischemic injury causing encephalopathy usually occurs antenatally or during labor or delivery, or may occur postnatally, but encephalopathy may sometimes be caused by another neonatal condition. For example, inborn error of metabolism or chronic diagnosis. Birth asphyxia has potentially serious medical legal implication. It has been recommended that infants who have the clinical features of HIE should only be considered to have birth asphyxia if there is evidence of severe hypoxia antenatally or during labor or at delivery. Resuscitation needed at birth, features of encephalopathy, evidence of hypoxic damage to other organs such as liver, kidney, or heart. No other prenatal postnatal cause identified. Summary: hypoxic ischemia encephalopathy is an important cause of morbidity and mortality worldwide. It's severe and causes encephalopathy, multi-organ dysfunction. Therapeutic hypothermia has become standard therapy in the UK and many countries if moderate or severe. Now the picture showing HIE, hypoxic ischemic from failure of oxygenation across placenta, umbilicus or postnatal respiratory depression, hypoxemia, hypercapnia, respiratory acidosis, and leads to low cardiac output, decreased tissue perfusion, ischemia, metabolic acidosis, capillary leak edema, hypoxic ischemia, encephalopathy with multi-organ dysfunction, encephalopathy, abnormal neurological signs, seizures, respiratory failure, persistent pulmonary hypertension of the newborn, myocardial dysfunction, hypertension, metabolic, hypoglycemia, hypocalcemia, hyponatremia, other organ dysfunction, renal failure, DIC, AEG monitor useful to confirm encephalopathy and identify seizures. The infant is wrapped in cooling mattress to maintain rectal temperature of 33 to 34 for 72 hours. Start cooling within 6 hours of birth. Avoid hypothermia more than 37.5. Therapeutic hypothermia for moderate to severe HIE. Mild hypothermia for moderate and severe HIE reduces death and severe disabilities and increases the likelihood of survival and normal neurological functions. Outcome of therapeutic hypothermia trials compared with standard care for the treatment of near-term babies with hypoxic ischemic encephalopathy. Figure shows reduction of death or major disability. Reduction seizures not just demonstrated, and there may be an increase in persistent pulmonary hypertension of the newborn. These are the risk ratios. The figures showing the MRI of the brain at 14 days term infant abnormal white signal in the basal ganglia and thalami, and absence of signals in internal capsulopatry carries high risk of cerebral palsy. Normal scans for comparison showing basal area and a white signal from myelin in the posterior limb of the internal capsule. Now, the birth injury, infants may be injured at birth, particularly if they are malpositioned or too large for the pelvic outlet. Injuries may also occur during manual maneuvers from forceps blades or at Vandu deliveries. Fortunately, now that C-sections is available in every maternity unit, heroic attempts to achieve vaginal delivery with resultant severe injury to an infants have become extremely rare. Soft tissue injuries, these include gap and secundanium, bruising and edema of the presenting part, extending beyond the margins of skull bone, resolved in a few days. Cephal hematoma from bleeding below the periosteum, confined within the margins of skull sutures, usually involves the parietal bone. The center of the hematoma feels soft, resolves over several weeks. Chignons is edema and bruising from Vandu delivery, bruising to the face after face presentation, and to the genitalia and buttocks after breech delivery. Preterm infants bruise readily from even mild trauma. Abrasion to the skin from scalp electrodes applied during labor or from accidental scalpel incision at C-section. Forces marked to face from pressure of blades, transient subaponeurotic hemorrhage, very uncommon, diffuse boggy swelling of scalp on examination, blood loss may be severe and can lead to hypovolemic shock and coagulopathy. Now, nerve palsy, brachial nerve palsy results from traction to the brachial plexus nerve roots. They may occur at breech deliveries or with shoulder dystocia. Upper nerve root C5 and C6 injury results in palsy. It may be accompanied by phrenic nerve palsy causing an elevated diaphragm. Palsy usually resolves completely, but should be referred to an orthopedic plastic surgeon if not resolved by 2 to 3 months. Most recover by 2 years. A facial nerve palsy may result from compression of the facial nerve against the mother's ischial spine or pressure from forceps. It is unilateral and there is facial weakness or crying, but the eye remains open. It is usually transient, but methyl cellulose drops may be needed for the eye. Really, nerve palsies may be from damage to the cervical spine when there is lack of movement below the level of the lesion. Now, the birth in the soft tissue in the secundanium, cephalohematoma, chignons, bruises and abrasions, subaponeurotic hemorrhage, location of extracranial hemorrhages. Show nerve palsies, brachial plexus nerve palsy, facial nerve palsy, and fractures clavicle, humerus, and femur. Behavior shows large scapula hematoma and lymphoid gignons, and that is palsy. Affected arm lies straight, is limp and with the hand pronated and fingers flexed. Waiter step position. So the fracture is usually clavicle, usually from shoulder dystocia. Snap may be heard at delivery, or the infant may have reduced arm movement on the affected side, or a lump from callus formation may be noticed over the clavicle at several weeks of age. Prognosis excellent, no specific treatment is required. Humerus in femur, usually mid-shaft, occurring at breech delivery or fracture of the humerus at shoulder dystocia. There is deformity, reduced movement of the limb, and pain on movement. They heal rapidly with immobilization. Stabilizing the preterm or sick infant. Preterm infants of less than 34 weeks gestation and newborn infants who become seriously ill require the condition to be stabilized and monitored. Many of them will need respiratory, circulatory, and nutrition support. The preterm infant, the parents, the likely clinical course, chances of survival, and long-term prognosis depend on the gestation age at birth. The appearance and maturation changes of very preterm infants are described in table. And the importance of parental involvement is shown, and the external appearance and logical findings can be scored to provide an estimate of an infant's gestation if not known from ultrasound scanning. The rate and severity of problems associated with prematurity decline markedly to increase in gestation. Infants born at 23 to 25 weeks gestation encounter many problems, require many weeks of intensive and special care in hospital, and have a high overall mortality. With modern neonatal care, the prognosis is excellent after 30 weeks gestation age. Respiratory distress syndrome, RDS, also called hyaline membrane disease. There's a deficiency of surfactant, which lowers surface tension. Surfactant is a mixture of phospholipids and proteins excreted by the type 2 pneumocytes of the alveolar epithelium. Surfactant deficiency leads to widespread alveolar collapse and inadequate gas exchange. The more preterm the infant, the higher the incidence of RDS. It is very common in infants born before 38 weeks gestation and tends to be more severe in boys than girls. Surfactant delivery deficiency is rare at term but may occur in infants of diabetic mothers and very rarely from genetic mutations in surfactant genes. The term hyaline membrane disease derives from a proteinaceous exudate seen in the airways on histology. Glucocorticoids given endonatally to the mother stimulate fetal surfactant production and are given if preterm delivery is anticipated. The evidence of their benefit is substantial. It significantly reduces RDS, bronchopulmonary dysplasia, and interventricular hemorrhage in infants less than 34 weeks gestation. At delivery or within 4 hours of birth, babies with RDS develop clinical signs of tachypnea over 60 breaths per minute, labored breathing with chest wall recession, particularly sternal and subcostal indwelling, and nasal flaring. Medical problem. The box shows medical problems of preterm infants, need for resuscitation, stabilization at birth, respiratory RDS, pneumothorax, apnea, and bradycardia, hypotension, PDA, temperature control, metabolic, hypoglycemic, hypocalcemia, electrolyte imbalance, osteopenia, prematurity, nutrition, infection, jaundice, interventricular hemorrhage, or periventricular leukemia, necrotised enterocolitis, retinopathy of prematurity, anemia of prematurity, iatrogenic, bronchopulmonary dysplasia, inguinal hernias. Now, continuing with RDS, the expiratory grunting in order to try to create positive air pressure due to expiration, maintain functional residual capacity, and cyanosis if swear. The characteristic chest X-ray appearance is shown. Treatment with raised ambient oxygen is required, and surfactant therapy may be given by instilling surfactant directly into the lungs via a tracheal tube or catheter. Additional respiratory support may be provided non-invasively with continuous positive airway pressure or a high-flow nasal cannula therapy, or invasively with mechanical ventilation via a tracheal tube. Mechanical ventilation with intermittent positive pressure ventilation or high-frequency oscillation is adjusted according to the infant's oxygenation, which is measured continuously chest wall movements in bowel gas analysis. Non-invasive respiratory support is used in preference to mechanical ventilation whenever possible, as it has fewer complications. Surfactant therapy reduces morbidity and mortality of preterm infants with RDS. Pneumothorax. In RDS, air from the over distended alveoli may track into the interstitium, resulting in pulmonary interstitial emphysema. In up to 10% of infants ventilated for the RDS, air leaks into the pleural cavity and causes a pneumothorax. When this occurs, the infant's oxygen requirement usually increases and the breath sounds and chest movements on the affected side are reduced. Although this can be difficult to detect clinically, a pneumothorax may be demonstrated by transillumination of the bright fiber optic light source applied to the chest wall or on a chest X-ray. Tension pneumothorax is treated urgently with decompression by inserting a chest drain in order to try and prevent pneumothoraces. Infants are ventilated with the lowest pressure has that provided adequate chest movement and satisfactory blood gases. Now the picture showing the stabilizing preterm of sick infants, airway breathing, respiratory distress, tachypnea, labor breathing, chest wall recessions, nasal flaring, expiratory grunting, and cyanosis. And the next one is apnea. Management as required, clear the airway, oxygen, continuous positive airway pressure, CPAP, and high flow nasal cannula therapy, and mechanical ventilation. Monitoring oxygen set, that's maintained at 91 to 95% if preterm, heart rate, respiratory rate, temperature, blood pressure, blood glucose, blood gases, and weight. Temperature control, place in plastic bag at birth to keep warm if extremely preterm. Perform stabilization under radiant environment with or without a heated mattress or in a humidified incubator to avoid hypothermia. Venous and arterial signs, peripheral intravenous line required for intravenous fluids, antibiotics, and other drugs. And umbilical venous catheter may be used for intravenous exercise resuscitation. Extreme preterm for the first few days or to administer high osmolarity fluids, high concentration dextrose or medications, meaning central delivery. Those are inotropes. Arterial lines, certain frequent blood gas analysis, blood tests, and continuous blood pressure monitoring are required. Usually umbilical artery catheter, sometimes peripheral cannula if for short period or no umbilical artery catheter possible. The arterial oxygen tension is maintained at 8 to 12, that is 60 to 90 millimeters of mercury, and the carbon dioxide tension and at 4.5 to 6.5, 35 to 40. Peripheral inserted central decline for parental nutrition if indicated. Inserted peripherally when it is stable. Chest X-ray with or without abdominal X-ray, assistant diagnosis of respiratory disorders, confirm the position of tracheal tube and central lines, investigation, hemoglobin, neutrophil count, platelet count, blood urea, creatinine, electrolytes, and lactate, culture, blood, plus minus CSF fluid, plus minus urine, blood glucose, and C-reactive protein, acute phase reactant, coagulation screen if indicated. Antibiotics, course of antibiotics are given. Minimal handling, all procedures, especially painful ones, adversely affect oxygenation circulation. Handling the infant is kept to a minimum and done as gently, rapidly, and efficiently as possible. Analgesia should be provided to prevent pain as necessary. Parents or the medical nursing staff are usually fully occupied stabilizing the baby. Time must be found for parents and immediate relatives to allow them to see and touch their baby and to be kept fully informed. The preterm infant maturation changes in appearance and development. Preterm infant 27 to 28 weeks, and then the other one is the term infants. The preterm infant compared with the term infant, birth weight 50th centile at 24 weeks male 700 gram, female 620 gram, term 37 to 42 weeks. At 40 weeks male 3.55 kg, female 3.4 kg. Skin very thin and thick skin, dark red color all over body, pale pink color. Ears penis soft, no recoil, penis firm, cartilage to edge, immediate recoil. Breast tissue, no breast tissue, palpable, one or both nodules. Genital scrotum smooth, no testes in scrotum. Male scrotum has rugae, testes in scrotum. Female prominent clitoris. Labia majora widely separated, labia minor protruding, labia minor clitoris covered. Breathing need respiratory support, apnea common. Really needs respiratory support, apnea rare. Sucking and swallowing, no coordinated sucking, coordinated from 34 to 35 weeks. Feeding usually needs parental nutrition and tube feeding. Cries when hungry, feeds on demand. Cry faint, and term infant has loud. Vision interaction, eyelid may be fused, infrequent movements not available for attraction. Make eye contact, alert wakefulness. Hearing, startles to loud noise, response to sound. And postural, limbs extended, jerky movements, flexible postures, and smooth movements. Parental involvement in neonatal care. Skin to skin contact between infant and parent kangaroo care promotes bonding. Parental involvement in neonatal care, mother giving her baby express milk and syringe via NG tube, nasogastric tube, allowing close eye and skin contact between mother and baby. These are chest X-ray in respiratory distress syndrome showing diffuse, granular or ground glass appearance of the lungs and an air bronchogram where the larger airway is outlined, the heart border indistinct. A tracheal tube is present. And the picture, figure 9.14 shows chest X-ray showing biliary pneumothorax in a preterm infant with respiratory distress syndrome. Now the apnea and bradycardia and desaturation. Episodes of apnea and bradycardia and desaturation are common in very low birth weight infants until they reach about 32 weeks gestation age. Bradycardia may occur either when an infant stops breathing for over 20-30 seconds or when breathing continues, but against a clue, what is underlying cause: hypoxia, infection, anemia, electrolyte disbalance, hypoglycemia, seizures, heart failure, or aspiration due to gastroesophageal reflux needs to be excluded, but in many instances, the cause is immaturity of central respiratory control. Breathing will usually start again after gentle physical stimulation. Treatment with a respiratory stimulant. Caffeine often helps and has been demonstrated to improve outcomes. CPAP or mechanical ventilation may be necessary if apneic episodes are frequent. Temperature control. Hypothermia causes increased energy consumption and may result in hypoxia and hypoglycemia, failure to gain weight, and is an independent risk factor for mortality soon after birth. Preterm infants are particularly vulnerable to hypothermia as they have a large surface area relative to their mass, so there is greater heat loss related to surface area than heat generation related to mass. Their skin is thin and heat permeable, so transepidermal water loss is important the first week of life. They have little subcutaneous fat for insulation. They are often nursed naked and cannot conserve heat by curling up or generate heat by shivering. There is a neutral temperature range in which an infant's energy consumption is at a minimum level. In the very immature baby, this neutral temperature is highest during the first few days of life and subsequently declines. The temperature of these small babies are maintained using incubators or initially with overhead radiant heaters. Incubator also allow ambient humidity to be provided, which reduces transepidermal heat loss. Now, patent ductus arteriosus. The ductus arteriosus remains patent in many preterm infants. Shunting of blood across the ductus from the left to right side of the circulation. Most common infants with RDS, it may produce No symptoms that may cause apnea and bradycardia, increased oxygen requirement, and difficulty in weaning the infant from artificial ventilation. The pulses are bounding from increased pulse pressure, and the precordial impulse becomes prominent. A systolic murmur may be audible. With increasing circulatory overload, signs of failure may develop. More accurate assessment of the infant's circulation can be obtained on echocardiography. If the infant is symptomatic, pharmacological closure with the prostaglandin synthetase inhibitor indomethacin or ibuprofen is used. If these may have failed to close the symptomatic, duct surgical ligation will be required. Now, the picture showing the temperature control, prevention of heat loss in newborn infants, convection, raise temperature of ambient air in incubator, clothed, including covered head, avoid dots. Second is radiation cover baby, double walls for incubators. Evaporation, dry and wrap at birth. In extremely preterm, place baby's body directly into plaster pad at birth without drying. Humidify incubator. Conduction, nurse on heated mattress. Importance of avoiding hypothermia in newborn infants has long been recognized. This incubator was used in the late 19th century to keep newborn infants warm. The sponge is to increase ambient humidity. So in balance, the preterm infant's fluid requirement vary with gestation and chronological age. It is suggested according to infant's clinical condition, plasma electrolytes, urine output, and weight change. On the first day of life, about 60 to 90 ml per kg is usually required, which increases by 20 to 30 ml per kg per day to 150 to 180 ml per kg per day by about day 5 of life. Nutrition: preterm infants have high nutrition requirement because of their rapid growth. Preterm infants at 28 weeks gestation double their birth weight in 6 weeks and triple it in 12 weeks, whereas term babies double their weight in only 4.5 months and triple it in a year. Infants of 35 to 36 weeks gestation age are mature enough to suck and swallow milk. Less mature infants will need to be fed via an orogastric or nasogastric tube. Even in very preterm infants, enteral feeds, preferably breast milk, are introduced as soon as possible. In these infants, breast milk needs to be supplemented with phosphate and may need supplementation protein and calories in breast milk fortifier and calcium in some neonatal units. Extremely preterm infants are initially fed on donor breast milk if maternal breast milk is not available. If in formula feeding is required, special infant formulas are available, which are designed to meet the increased nutritional requirement of preterm infants, but in contrast to breast milk, do not provide protection against infection or other benefits of breast milk. In the very immature or sick infant, typically less than 1 kg birth weight, parenteral nutrition is often required. This is usually given through a periphery inserted central line, PICC or long line, or an umbilical venous catheter, paying strict attention to aseptic technique both during insertion and when lines are accessed. Central lines carry significant risk of septicemia. Other risks include thrombosis of a major vein. For this reason, parenteral nutrition may sometimes be given via a peripheral vein, but extravasation may cause skin damage and scarring. Because of significant risk of septicemia from parenteral nutrition and the increased risk of necrotizing enterocolitis with cow's milk-based formula, mothers should be encouraged and supported to provide breast milk. Poor bone mineralization, osteopenia of prematurity was previously common but is prevented by provision of adequate phosphate, calcium, vitamin D, because iron is mostly transferred to the fetus during the last trimester. Preterm babies have low iron stores and are at risk of iron deficiency. This is addition to loss of blood from sampling and an inadequate erythropoietin response. Iron supplements are started several weeks of age and continued after discharge home. Necrotizing enterocolitis showing gross abdominal distension, tense and shiny skin over the abdomen, air in the diaphragm from bowel perforation, in the diaphragm and abdominal X-ray, air in portal tract, distended bowel loops, intramural air in Neck. Characteristic features of neck. Infection. Preterm infants are at increased risk of infection as IgG is mostly transferred across the placenta in the last trimester. No IgE or IgM is transferred. In addition, infection in or around the cervix is often a reason for preterm labor and may cause infection shortly after birth. Most infections preterm infants occur after several days of age and are nosocomial, hospital-derived. They are often associated with indwelling catheters or mechanical ventilation. Infection is considered in more detail later in this chapter. Infection preterm infants is a major cause of death and contributes to bronchopulmonary dysplasia, brain injury, and later disability. Now, necrotizing enterocolitis, serious illness, and one of the greatest challenges facing modern neonatal medicine today. The incidence increases with increasing prematurity as is typically seen in the first few weeks of life. The bowel of the preterm infant is vulnerable to ischemic injury and bacterial evasion, both key risk factors for necrotizing enterocolitis. Preterm infants fed cow milk formula are most likely to develop this condition than if they are fed only breast milk. Supplementing milk feeds with prebiotics or probiotics may also be beneficial. Early signs of necrotizing enterocolitis include feed intolerance and vomiting, which may be bile stained. The abdomen becomes distended and the stool sometimes contains fresh blood. The infant may rapidly become shocked and require mechanical ventilation because of abdominal tension and pain. The characteristic extra features and distended loop of bowel and thickening of the bowel wall with intramural gas, and there may be gas in portal venous tract. The disease will progress to bowel perforation, which can be detected by X-ray or by transillumination of the abdomen. Treatment is to stop overfeeding and give broad-spectrum antibiotics to cover both aerobic and anaerobic organisms. Parenteral nutrition is always needed, and mechanical ventilation and circulatory support are often required. Surgery is performed to bowel preparation. The disease has significant morbidity and mortality. About 20% long-term sequelae include development of strictures and malabsorption if extensive bowel dissection has been necessary, as well as a greater risk of poor neurodevelopmental outcome. Now, preterm brain injury. Hemorrhages in the brain occurs in 20% of very low birth weight infants, easily recognized on cranial ultrasound scans. Typically, they occur in the germinal matrix above the caudate nucleus, which contains a fragile network of blood vessels. Most intraventricular hemorrhages occur within the first 72 hours of life. They are more common following perinatal asphyxia and in infants with severe RDS. Pneumothorax is a significant risk factor. Antenatal glucocorticoids prior to preterm infant delivery is associated with reduction in the incidence of severity of RDS and therefore of IVH. Small hemorrhages are confined to germinal matrix, but larger hemorrhages extend into the ventricles. Most severe hemorrhages unilateral hemorrhagic infarction involving the parenchyma of the brain. This usually results in hemiplegia. A large IVH may impair the drainage and reabsorption of CSF, thus allowing CSF to build up under pressure. This dilation may result spontaneously or progress to hydrocephalus, which may cause the cranial sutures to separate, the head circumference to increase rapidly, and the anterior frontline to become tense. A ventricular peritoneal shunt may be required, but initially symptomatic relief may be provided by removal of CSF by lumbar puncture or ventricular tap. About half of infants with progressive post-hemorrhagic ventricular dilatation have cerebral palsy, a higher proportion if parenchymal infarction is also present. Periventricular white matter brain injury may occur following ischemia or inflammation, even in the absence of hemorrhage. It is more difficult to detect by cranial ultrasound. Initially, there may be an echodense area of flare within the parenchyma. It may resolve within a week, in which case the risk of cerebral palsy is not increased, but if cystic lesions become visible on ultrasound 2 to 4 weeks later, there is a definite loss of white matter. Bilateral multiple cysts called periventricular leukomalacia have an 80 to 90% risk of spastic diplegia, often with cognitive impairment if posteriorly sighted. Both IVH and periventricular leukomalacia may occur in the absence of abnormal clinical signs. Similarly, although cranial ultrasound abnormalities associated with later disability, about a third of premature infants less than 32 weeks gestation who go on to have cerebral palsy have a normal cranial ultrasound, which suggests that more subtle neuronal injury can occur long-term, can cause long-term disability. Now, the cranial ultrasounds in preterm infants and coronal section and parasitical section, normal at times, Sylvan Fisher's level of third ventricle, interventricular periventricular hemorrhage with dilatation of both lateral and ventricle, germinal layer hemorrhages, and severe paraventricular leukomalacia, paraventricular cyst, and increased echo density of white matter. Now, parasagittal and the choroid plexus and through lateral ventricle and the germinal layer hemorrhage. And the next phase is periventricular cyst and increased echo density of white matter. And these are the ultrasound, large ventricular hemorrhage with parenchymal hemorrhagic infarct on the right, and dilatation of the lateral ventricles following intraventricular hemorrhage, and widespread cyst and periventricular leukomalacia. Now, the retinopathy of prematurity. Retinopathy of prematurity affects developing blood vessels at junction of the vascularized and non-vascularized retina. There is vascular proliferation, which may progress to retinal detachment, fibrosis, which may progress to fibrosis and blindness. It was initially recognized that the risk is increased by uncontrolled use of high concentration of oxygen. Now, even with careful monitoring of the infant's oxygenation, retinopathy of prematurity is still identified in about 35% of all very low birth weight infants. Eyes of susceptible preterm infants less than or equal to 1500 gram birth weight or less than 32 weeks gestation are screened by an ophthalmologist. Laser therapy reduces visual impairment, and intravitreal anti-VEGF, antivascular endothelial growth factor therapy is being investigated. Severe bilateral visual impairment occurs in about 1% of very low birth weight infants, mostly infants less than 28 weeks gestation. Bronchopulmonary dysplasia. Infants still have an oxygen requirement at a post-menstrual age of 36 weeks are described by having bronchopulmonary dysplasia, previously called chronic lung disease. The lung damage is now, though, thought to be mainly from delay in lung maturation, but may also be from pressure and volume trauma from artificial ventilation, oxygen toxicity, infection. Chest X-ray characteristically shows widespread areas of pressification. Sometimes 6 changes. Some infants need prolonged artificial ventilation, but most are weaned onto CPAP or high flow nasal cannula therapy, followed by additional ambient oxygen, sometimes over several months. Corticosteroid therapy may facilitate early weaning from the ventilator and often reduce the infant's oxygen requirements in the short term, but concern about increased risk of abnormal neurodevelopment, including cerebral palsy, limits used to those at high risk, and only short low dose courses are given. Some babies go home while still receiving additional oxygen. A few infants with severe disease may die of intercurrent infections or pulmonary hypertension, subsequent pertussis, and respiratory viral infection. For example, respiratory syncytial virus or rhinovirus may cause respiratory failure, necessitating intensive care. Problems following discharge. Some of the medical problems like to be encountered on discharge from hospital are summarized in case history. About 5 to 10% of very low birth weight infants develop cerebral palsy, but the most common impairment are learning difficulties. The prevalence of cognitive impairment and of other associated difficulties increases with decreasing gestation age at birth, and it is greatest if born at a very early gestation, less than 76 weeks gestation. It becomes increasingly evident when the individual child is compared with their peers at nursery school. In addition, children may have difficulties in fine motor skills, threading beads, concentration with short attention span, behavior problems, especially attention deficit disorders, abstract reasoning, for example, mathematics, processing several tasks simultaneously. A small proportion also have hearing impairment with 1 to 2% requiring amplification, or visual impairment, 1% blind in both eyes. A greater proportion have refraction errors and squints and therefore require glasses. Follow-up studies of very preterm infants who are now adults indicate that they are less socially engaged, are poor in communication, and easily become worried compared with their peers, impact adversely on relation and careers. During infancy, extremely preterm infants, especially those who had bronchopulmonary dysplasia, are at increased risk of respiratory failure from bronchiolitis, other low respiratory tract infections. Now, the case history, ex-preterm infant going home. Muhammad was born at 4 weeks gestation. The care pathway showing the potential problems and their timing for an infant born at this gestation is shown. He's about to be discharged from the neonatal unit at 41 weeks gestation. 8 he starts planning meeting, identify his need when going home, included home oxygen for his bronchopulmonary dysplasia. He will have respiratory reviews to allow him to wean safely off his oxygen with growth, respiratory syncytial virus prophylaxis during the winter months to reduce the risk of readmission and need for respiratory support, cardiac monitoring to make sure he's not developing pulmonary hypertension, dietitian input, he's breastfeeding and taking preterm formula, his phosphate, iron, vitamin needs will need to be considered. He has already had 2 sets of primary immunization at a normal time, and this course needs completing. He's at greater risk of inguinal hernias. Ophthalmology review will monitor his early retinopathy prematurely and decide if any treatment is required. Low threshold for hospital readmission, rate increase fourfold, and mainly for respiratory disorders. In addition to the Healthy Child program for all children, his growth and neurodevelopment will be monitored, especially during the early years of life. The care pathway for 22 weeks infant showing potential problems and their timing. Temperature, respiratory, CVS, everything is monitored, GIT, and nutrition, metabolic, jaundice, add infections, and then eyes, and then brain and hemorrhage in potential problems and their different timings. Summary of problems of very low birth with infants 1.5 kg, and for 1.5 kg, respiratory distress syndrome, that is RDS, affecting deficiency, 74% respiratory distress within 4 hours of birth, antenatal corticosteroids of spectrum therapy reduce morbidity and mortality, oxygen therapy by excess may damage the retina, nasal CPAP, continuous positive airway pressure, 67%, mechanical ventilation, 64%, often required to expand lungs and prevent lung collapse. High flow nasal canal therapy may also be used, 51%. Pneumothorax is 4%, apnea and bradycardia and desaturation, bronchopulmonary dysplasia, oxygen requirement 36 weeks, post-menstrual age 27. Circulation hypertension may require volume support. Anaerobic corticosteroid, PDA needing medical treatment 34%, surgical ligation 8%. Nutrition, NG tube feeding until 35-36 weeks, post-menstrual age, feeding intolerance, parenteral nutrition often required. GIT necrotizing neck, 6%, serious management, used for medical surgery for bowel necrosis, perforation, metabolic, hypoglycemia, common electrolyte disturbances, osteogenesis or prematurity from phosphate deficiency, hearing, checked before discharge, jaundice common, low treatment threshold, anemia often need blood transfusion, eye retinopathy of prematurity may need laser therapy, 4%, temperature control, avoid hypothermia, nurse in neutral thermal environment, nurse in incubator under radiant warmer, clothe if possible, humidity reduces evaporation, heat loss, infection, common and potentially serious 25% increased risk of early onset infection would be streptococcus. Main problem is nosocomial infection, mainly coagulase negative, staphylococcus, also fungal and other infections, brain injury, hemorrhage is 20%, germinal layer intraventricular parenchymal, ventricular dilatation may need ventriculoperitoneal shunt, periventricular leukemia, 3% ischemia, white matter injury. Following discharge, specialist community nursing support helpful if available. Increased risk of respiratory infection, wheezing, especially from bronchiolitis caused by respiratory syncytial virus, RSV, and pertussis, may need intensive care. Consider prophylaxis against RSV infection. Increase re-hospitalization, respiratory disorders, inguinal hernia. Monitor growth, development for learning disorders, coordination, cerebral palsy, behavior, attention, vision, hearing, increased risk of impairment.